The content discussed in this episode may be specific to the guest's organisation or location and may not be applicable to other organisations, states, territories or countries. The material presented in this podcast is for general information purposes only and should not be considered health, legal or financial advice. Medical administration is a rewarding profession, but it comes with challenges. So what is it like, and what should you do if confronted with a monumental administrative difficulty? This is the podcast that takes unfortunate scenarios and explores the essentials of clinical governance to find solutions. I'm Dr David Rankin, a very experienced medical administrator and lead fellow with the Royal Australasian College of Medical Administrators. And this is Safeguarding Healthcare, the essentials of clinical governance. Today, balancing passion and burnout.
Doctors find it notoriously difficult to detect burnout in themselves, and it's often something that's first detected by the people around us.
That's Associate Professor Beth Kotze, a senior medical administrator and a psychiatrist who is the Director of Children and Adolescent Mental Health Services for the Sydney Local Health District. And I'm presenting her with a difficult scenario.
The gaining of resilience is a lifelong journey for all of us.
In today's scenario, a senior medical registrar has been putting in very long hours over the last few months. They are always willing to fill the extra shift and usually receive exceptional reviews for their placements. Over the past week, they have been rostered for day shifts on the wards, but have also worked 3 nights as the department has been faced with a lot of sick leave and no one else is prepared to fill the roster. Today they've been very short with the nurse unit manager and then burst into tears when a senior colleague suggests that they may not have handled the situation very well. They admit that they have been struggling with their mortgage obligations, they have not been sleeping well, and their relationship is going through a rough patch at present. I started by asking Beth what key issues this scenario raises.
Unfortunately, it describes a very common situation. You have a young doctor who's working very hard, has high standards and a good track record at work, who's under significant and sustained high caseload, in this case for a relatively brief period of time, but still a few months. And I'm guessing as a senior medical registrar, it's a caseload of complex patients. They're working very long hours. There's possibly a touch of martyrdom in the taking on of extra shifts. And of course, that's something that comes up very interestingly in the studies that have been done of doctors who experience burnout. And of course, in this circumstance, it's of significant benefit both to the doctor and the organisation, their willingness to take on extra shifts. But it's not always in a very positive way, of course. And then there's an event that triggers the opportunity to focus in on what is happening for this young doctor.
It's not always just the young doctors who get burnout. On a personal basis, what are the sort of symptoms that we should be looking for in ourselves to determine whether or not we're faced with burnout or it's time to pull back?
Yes, doctors find it notoriously difficult to detect burnout in themselves. And it's often something that's first detected by the people around us, by the members of the multidisciplinary team or our family, who notice that we're more fatigued, irritable than usual, or just less emotionally available, and perhaps seem relentlessly negative about our work, which is a change from our usual attitude. The very qualities that can make us good doctors and the defences that we use in order to do the work required don't unfortunately serve us well when we're faced with high levels of stress, and particularly sustained stress in the workplace. So one would hope that you might notice at some point in time feelings of fatigue and loss of energy that simply don't respond to the usual things that you would do to revive yourself at the end of the day. So it's an enduring fatigue and lack of energy, a feeling of disengagement from work, a feeling of being on automatic pilot, of not being interested in the patients and the problems that they present, and perhaps a feeling of increased callousness towards patients. The other impact, though, is a sense of ineffectiveness and loss of efficiency. So doing more hours, putting in more effort, and yet realising less benefit from that work. And those kind of three domains of burnout contribute to a sense of decreased effectiveness at work. Now, the doctor themselves, you might realise yourself that things have changed, your work is just not as satisfying, you're not as engaged, you don't feel as effective, time feels slowed down, and yet you're not accomplishing all the things you usually would. But it's often something that other people tentatively draw to people's attention, hopefully not in a crisis situation, as has happened with this young doctor. But yeah, it's very difficult to recognise in yourself often.
Medicine provides that nasty challenge, I guess, made a commitment to look after patients, but the demands of patients always exceed the amount of time available by doctors. We simply don't have enough doctors in Australia to service the needs of all the patients. How do we pull back, I guess, or more specifically, what's the treatment for burnout?
I guess in terms of the first part of your question, the gaining of resilience is a lifelong journey for all of us, and that's about how we use our experience of life and potentially our experience of trauma, which of course in the area of healthcare can include adverse incidents, for example, for psychiatry, the suicide of a patient, and how you use those experiences to manage your emotions, to ensure that your problem-solving skills are as optimal as they can be, to manage with flexibility and humour the stresses and strains that your work presents. But it's very challenging in the modern healthcare environment. You have an environment of constrained resources, of perpetual, if you're lucky, it might be periodic, but it's often perpetual churn. There are workforce shortages. There can often feel like there are limited ways in which doctors can engage in improving the context in which they're working, all of which contributes to a sense of loss of autonomy and effectiveness. So look, generally, the work that's been done in the burnout space for doctors would emphasise that you need to look at what's happening for the individual, but you must look at what's happening in the organisation. And in fact, there's some evidence that if you do the first without the second, you're going to be less effective in addressing the problems of burnout in your organisation. So you must look at the systemic factors that are perpetuating burnout. So for the individual doctor, it's the things that actually encourage them to feel empowered in their work context, to feel that they are developing and maintaining their mastery in their craft, and that they are attending to the other things that look after their health and their mental health. So if you like, the package is one of ensuring that doctors don't feel isolated, ensuring that they do have collegial support, ensuring that supervision mechanisms for junior trainees are available and predictable, ensuring that there are spaces for individual and group debriefs, ensuring that there are very particular responses to critical and adverse events which are likely to invoke a response of guilt or grief in the doctor and can be very important in leading to burnout. There's all the general things that you would think about building a strong general health and mental health, and that's diet and exercise, looking at drug and alcohol consumption, cigarette use, ensuring that your lifestyle actually means that you are robust and able to meet these challenges in the workplace. But of course, there's a lot of evidence that actually maintaining your resilience or building your resilience like that actually contributes to your decision-making capacities as a medical practitioner. It also contributes to the patient experience of you in the giving of care in a very positive way. And of course, it's well shown that doctors maintaining their own physical and mental health, their experience of their social relationships and their community, so their connection to friends and family also improve. And all of that will help either prevent the doctor experiencing burnout or it mitigates some of the stresses in the workplace. But over and above that, it's incredibly important to look at what's happening in the workplace. And of course, it starts with leadership, an organisational commitment to addressing the factors that contribute to burnout in the health service. And of course, that's incredibly important. Once your leaders appreciate that actually it drives staff turnover, it drives premature retirement, it actually has a contagion effect within teams. So one burnt out member of a team can result in your whole team starting to be suboptimal in their performance. So it costs money to the business. It reduces patient care and safety. So it also has a very significant cost in that regard. And so putting in place some proactive and preventative measures can be of great benefit to the organisation. Organisations do it differently. Some organisations have gone down the path of establishing, working parties and committees, chief medical wellbeing officers, for example, whose job it is to craft a strategy that looks at all the kind of mechanisms that you can put in place, like supervision, like looking at civility in the workplace and the various ways in which you can build positive working relationships, improve communication in the multidisciplinary team, reduce isolation and increase the spaces for people to be able to discuss what it's like, the work that they're doing and the impact it's having on them.
Beth, what does an appropriate organisational response look like?
One of the important things in the organisational response is, yes, you work through all the issues like, do your policies and procedures support people being able to take leave when they need it? Do your policies and procedures support being able to detect when people are working unreasonable hours? Do your policies and procedures support the creation of spaces that enable multidisciplinary teams to function well? So you do need to work through all that, but then you also need to have mechanisms for the early detection and intervention when doctors are becoming burnt out. So, for example, with our senior medical registrar, this looks like a really good opportunity for early intervention, in which case you do sit down with the doctor, talk to them about what is happening, recognising that doctors may find it very difficult to acknowledge burnout, taking an empathic but quite firm stance in relation to what the next steps should be, addressing some of their concerns in relation to privacy and the fact that they've had this outburst in the workplace and what that's going to be like for them for the future in the relationships with the multidisciplinary team, talking to them about any concerns they might have about family responsibilities and how the family are reacting to what's currently happening for them, and looking at what you immediately need to do to relieve them of the stress of this situation.
Thinking about the registrar in the scenario, how are we going to help them recover from this incident and develop resilience?
In this kind of situation, it's clear this person needs a break, and you can take away from them the responsibility of doing these additional shifts as well. That's an organisational responsibility. So once you've actually talked to the medical registrar about this very initial action that needs to be taken, you then need to round back and look at how this could have happened in this organisation. One of the really interesting things about this predicament is that you're very interested in their vulnerability factors for experiencing burnout, and it may be that it is as simple as excessively long hours, but there might also be other things that you need to understand. You would have a look at what has happened over that recent period, both from the point of view of the individual's doctor's experience and whether there have been any adverse events or problems, issues, patient complaints, etc., but also from the point of view of being able to assess the organisational risk and understand what you need to do to mitigate that risk.
You raise a couple of fascinating points about that. The first one I'd like to address is doctors often can't see the burnout developing in themselves. They need an independent person. I guess that's easier when you're a junior medical staff working under supervision with a director of clinical training that can take you aside. Once you become a registrar or certainly a consultant, to have a mentor can often be seen as a failure. Can you talk to me about how doctors can go about getting an independent person that can tap them on the shoulder and say, hey, come on?
Look, it's an incredibly important point, and it is very true, and it's one of the factors that contribute to the relative isolation of the more senior doctors. Although I would just say that the Australian evidence actually supports that doctors in their more junior years are more prone to burnout, and in fact the rates are reduced the more senior the doctor. However, what it doesn't tell us is the relative difference in the experience of burnout, whether it's a more severe syndrome in the older doctor and more inclined to tip into or transform into a mental illness or mental disorder. So certainly that's a sort of interesting phenomenon that's been found in Australian doctors. Look, the issue of mentorship is absolutely critical, and it goes to the whole topic of the importance of isolation that sits often at the centre of the experience of burnout. And you're right, more junior doctors have ready prescribed access to those kind of support mechanisms, and it is often seen as a shameful thing for older doctors. It does, however, really support the case for peer review as part of doctors' mandatory CPD, and it's certainly mandatory in the College of Psychiatrists, that there is a formal process of peer review with colleagues. And the other thing in it is it does go to the topic of how you create all the informal mechanisms within organisations to enable good collegial relationships. And that's a whole variety of things. The departmental meetings that look at quality and safety and the monitoring by peers of quality and safety within department. The formal teaching activities like rounds and case presentations. They're again an opportunity for people to have those kind of collegial connections and discussions, encouraging informal collegial discussions about particularly complex patient predicaments. But it is actually an interesting phenomenon with doctors, and it can be a very sensitive topic, and too often it can actually slide into a discussion about kind of formal supervision, which is very problematic for experienced consultants, but may be, of course, necessary depending on the circumstances. So I think those things are to be encouraged as part of the fabric of communication and relationships within organisations, done in such a way that it is engaging for your senior consultants.
One of the challenges that you also raise is causation, I guess. Some of the causation of burnout is external to the hospital environment. As a medical administrator, how much responsibility should you take for addressing external environmental causes that are impacting on medical staff performance?
So the issue becomes understanding in a holistic way what is actually happening for this doctor and the importance of both addressing the sources of stress, but also, of course, what you want to do is mobilise the supports that are available to them within their family, friends and community. So you may well decide that it is actually appropriate with their permission to engage with other members of their circle in order for them to be able to understand what's happening for their doctor, their loved one, and to be able to respond and support them through this period of time. So it might well be that kind of explanation and looking at how they can be usefully included in the response is actually part of what you do. Look, at the end of the day, burnout is an occupational syndrome. It's quite specific to the occupational context. You don't diagnose it or identify it in other contexts, and the evidence is overwhelming that it is the workplace experience that actually drives the syndrome. And as I said before, it costs the organisation both both in terms of patient safety and quality, has a huge impact on patient experience of care, and it costs money from a workforce point of view. So it does need to be addressed proactively and vigorously.
And that brings us to the flip side of this, is the patients that the person's caring for. Their clinical decision-making is compromised. They may be making mistakes in treatment planning or medication dispensing or prescribing. How do you go back and make sure that the patients that the doctor suffering from burnout has treated have received appropriate care?
So in that first conversation with the doctor, you'd be asking yourself about the extent to which this reflects an inefficiency, a diminution in work capacity versus crossing the threshold to impairment. So you'd certainly be bearing that in mind. And then you would have a number of conversations with others who have had line of sight of their performance over this period of time. And that would be hopefully their supervisor, their senior clinical colleagues. It might be that, in fact, the emergency department director, in the circumstance of this senior registrar, would also be able to provide comment about their performance over this period of time. Depending on those conversations, you'll be constructing the kind of risk assessment that you need to undertake appropriate to the circumstances. And that might well include a look back on those, I think it was 3 extended shifts in the emergency department and the other extended shifts or workload over the several months. So you'd be looking for some kind of signal that tells you the threshold has been crossed to a performance issue or impairment. Now, of course, you might not get any information from those sources, but still remain concerned, in which case you may well initiate yourself a review of the decision-making and the outcome for those patients over that period of time. If you do decide, of course, that it has crossed the threshold, then a number of other processes and policies become invoked. So if you decide that, in fact, this is an impaired clinician and there is concern, reasonable level of concern, that there has been an impact on patient care, then, you would follow the organisational process for reviewing, and that may include quite extensive look back.
The really difficult question I find is the doctor that doesn't take advice. How do you deal with the doctor that denies that they are suffering from burnout and they're just going to soldier on?
Well, unfortunately, that phenomenon of soldiering on is highly prevalent in medical in medical staff. And of course, it goes along with all those fine qualities of being focused and dedicated, committed, being deeply immersed in your work, constantly striving to improve patient care. So it's a very important part of our repertoire when it comes to our work, but doesn't serve us perhaps well when there might be a whole variety of feelings that we're dealing with to do with our work, including, guilt and stress, the feeling of not being able to solve all the problems that we're confronted with. So the first thing is recognising sensitively the dilemma for the doctor and having that empathic discussion with them that it isn't a failure. It is something that is happening, that the people around them are concerned about, and trying to convey that sense of concern and support, and the idea that we need to deal with this situation as we find it, and we'll work through the other issues or concerns as that becomes appropriate. Sometimes that means a very firm discussion, and that might mean discussing with other senior colleagues who's best placed to have that sensitive conversation with the person concerned. It tends to be somewhat easier with more junior staff because, of course, there's already mechanisms set up for supervision and mentorship, and you can work through those. As you were saying before, it becomes somewhat a different situation with more senior medical staff, and that might become how you mobilise a more collegial peer response. You mightn't be the right person to have that conversation. It might also be that there's another senior colleague that actually doesn't have an established relationship with that person who's better placed to have the conversation. But you do need to think it through in the service of getting the best outcome for the individual doctor, which is that they feel reasonably okay about, for example, going on immediate leave, taking sick leave, etc. And of course, you'd have to work through all those options with them, again, very carefully. Talking to them about what additional support they might need. And that can be a whole variety of options. So it's very good to have in your mind ahead of time what are the access options for this doctor to get help. It's a great idea for all doctors to have their own GP. And hopefully, if they have a GP, they can actually speak with them about what is happening and look at the options there. It might be appropriate to offer something like EAP. I often find that doctors prefer, though, referrals to either senior medical colleagues or to senior clinical psychologists for assessment and more specific treatment.
It raises the whole issue of confidentiality, particularly amongst colleagues who watch the doctor deteriorate, concerned about them, and yet the doctor themselves is very protective of their privacy. How do you assure other staff that you're taking the issue seriously while protecting the confidentiality of the doctor that's suffering from burnout?
Look, hopefully, ahead of time, you've actually given some thought to how you create a culture in which actually it is okay to recognise, to be concerned about colleagues, to reach out to them if you do notice that there is distress, but also a culture in which the whole topic of burnout has been averted. It's okay to talk about it and people have a sense of how the organisation will respond. That, of course, that atmosphere makes it much easier to address the issues that you've raised. Now, of course, that's the ideal and is frequently missing in my experience. You do need to very sensitively have the necessary conversations, always bearing in mind that privacy, it is paramount, and there are various ways of working with concern about somebody whilst maintaining privacy. You also do need to have that conversation with the doctor, and I would always say something about, having listened to what their concerns might potentially be, say something about, their privacy being paramount, except, of course, under particular circumstances, and then only on a need-to-know basis. And the obvious one is if you're concerned about their safety or the level of impairment or the possibility of a mental illness. But it's actually telling people that those conversations may be necessary under the circumstance so that they're respectfully advised.
Thank you, Beth. That's been extraordinary. Just to finish things up, we all face pressure at work. We're busy. What advice would you share with other doctors to help us cope with the threat of burnout?
So what I'd share is that resiliency in life is a lifelong journey, and we all have the opportunity to construct our resiliency. And that means paying very careful attention to our physical health and our mental health. It means pursuing and growing and developing the other parts of ourself apart from our professional identity. And of course, that's partly our relationships with other people and the community. It's also partly pursuing other passions and interests in life outside of medicine. So it really means practicing as well. Things like exercise through to meditation and mindfulness, which is a very important skill in terms of building resiliency and coping with stress, and seeing that as a lifelong journey. It also means trying to take those kind of messages into the health workplace and looking to how you can positively contribute to a positive organisational culture. And it also means putting the problems and pressures of the workplace into a perspective that enables you to contribute to the solutions in the workplace. And of course, that's a kind of complicated undertaking because it depends as well on the willingness and the readiness of an organisation to hear what its clinicians have to say. But it means, how do you get things done? How do you identify the communication mechanisms that are available to you? And how do you contribute positively to whatever is happening in the organisation, whether that's major change projects around even things like the implementation of IT systems, for example, how administrative processes either support or impede the flow of work. looking at how you can contribute to those processes that construct what it's like to work in that organisation.
That was Associate Professor Beth Kotze, the Director of Children and Adolescent Mental Health Services for the Sydney Local Health District. And that brings us to the end of this episode of Safeguarding Healthcare. I'm Dr David Rankin. Follow Safeguarding Healthcare free on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to podcasts. This podcast is produced by Sound Cartel for the Royal Australasian College of Medical Administrators.